I'm Kim Lett. I'm chair of the local transition council, the Fredericksburg Area Council on Transition. That's called FACT. We're composed of individuals that work in the area of transition, from the schools to Department of Rehab Services, to the Community Services Board, to the Disability Resource Center, employment support organizations, and some parents. Okay, Dr. Kaul, we'll be ready to go whenever you're ready to go. You just let us know.
I appreciate it. Yep, I'm loading up the Zoom meeting now. My computer is causing me to have anxiety today. So it's a good topic. I will introduce myself just kind of briefly. I'm Adam Kaul. I've been working in the IDD world for 20 plus years. I have a private practice. I'm sitting here in my office in Midlothian, Virginia, and I've been doing that prior to doing that for 20 years, or at least part-time while doing that. I also worked in one of our training centers down here in Richmond at Southside Virginia Training Center, part-time while also working with IDD individuals here. I'm a psychiatrist. I teach a little down at VCU in that area of IDD, plus a few other areas. My first kind of love was geriatrics, and then from there brain injury, and then from there IDD. As any one of us probably can tell you, when you start working in the IDD world, you go from the Scrooge and your heart just gets that 4 sizes bigger, and you love working with individuals with IDD, and you become not just a provider of services, but an advocate and a true caregiver. So doing things like this is always rewarding for me, to get to talk to families and advocates and teachers, you guys who are really on the front lines in working in IDD. I also work with our REACH program. For those of you who are not familiar, each of our 5 healthcare provider regions has a REACH program, which is for crisis services for folks with intellectual and developmental disabilities. They have a good slew of resources. The Northern Virginia region certainly has good resources also available, and usually from time to time offer some degree of community trainings. So, I certainly would use them as a resource, especially for any crisis needs. And I'll be happy to talk online or offline about the REACH program, if anybody has questions. So tonight we're going to chit chat about anxiety. And can everybody see my screen now?
Mm-hmm. Yes.
Big block letters, because I have no sense of fashion or style whatsoever. So we're going to chit chat for a bit about that. And again, if you have a question or a thought, bring it in. This talk, I modified it a bit for what we're doing, but this is the same kind of talk I'll give to caregivers and providers of services, QMHPs, REACH staff, nurses, sometimes other physicians, families. So some of this kind of has a smorgasbord of information in it, but I like it because we can tailor it by way of discussion to suit our needs tonight. A couple of things to note about anxiety. Everyone pretty much has anxiety at some point in time in their life, and it's a universal thing. It's the most common amongst the psychiatric symptoms. So we think of psychiatry, we think of depression. That's kind of the one of the first ones that come to mind. But anxiety is actually significantly more common. And what is anxiety? It's a state of the affective sense of not feeling well. Not just worried about something, but it takes an actual effect on that person's life. And so how do we discern between what we would call just anxiety or just worry, regular day-to-day worry? I got to pay the bills. I got a meeting to go to. I got to make it to the gym tomorrow, whatever, those types of things, versus anxiety and anxiety disorders. And so the way we look at that psychiatrically is to say, okay, well, how does that affect a person's life? Is it causing a negative impact on that person's life? But it's not cut and dry. It's on this big continuum. So, a person who, worries about, let's say, paying the bills, is probably going to be further along that continuum if they don't have resources to pay those bills than the person who has plenty of resources to pay those bills, and they probably be less on that anxiety continuum. So much so that, continuous and chronic worry of that could lead to where we would qualify that in that anxiety disorder. So thinking about anxiety as just this or this is not how we want to look at anxiety. Think of it as this large continuum. But it's not a transient thing, generally speaking. And along with it comes that physical sense of discomfort. A person who has anxiety doesn't feel good about it. Okay, so and we talk about that in the space of intellectual and developmental disabilities, where we will see persons who have certain types of behaviors that may look like anxiety, but they're actually serving a purpose. So when we look at folks with sensory needs or obsessive compulsive type symptoms, this may be something that looks like an anxiety disorder, but that person is not uncomfortable with it. And so it's very important when we are trying to identify what our treatment plan is that we don't mislabel anxiety. So while anxiety is very, very prevalent and often missed in our folks with intellectual and developmental disabilities, it is sometimes mislabeled as something else. So we, again, things like sensory needs and, folks with autism spectrum disorder can have things that look like anxiety that may not be. More often, they have anxiety and we just may not be doing what we need to do about it. But it is important to note that it can be also mistaken. And that sense of needing to get away. So what's that unease feel like? And so there's a whole host of symptoms that you can see, restlessness, sweating, elevated pulse, the heart racing, feeling tired, poor concentration, inattention, distractibility, memory problems, irritability, muscle tension, tightness, headaches often come along with that. And so a tension headache, so people often ask about different types of headaches. So a migraine headache tends to be one side. A sinus headache tends to be kind of here and focused, maybe in the back of the head. A tension headache tends to usually be like a band. There's something also called cluster headaches, which can kind of be in various areas, but that tension headache, and it tends to be, as the day goes on, more likely to get that tension. So any of us who've had long, hard days, maybe didn't get a good night's sleep, we may have had those tension headaches. Tension headaches are common with anxiety disorders. Insomnia, difficulty with sleeping. Usually the person is having trouble getting to sleep because they are worrying. They're mentally trying to get themselves to bed, and they say, okay, well, I'm constantly worrying about what the next day holds for me. In a number of our folks and the folks we're caring for, we can often see challenging behavioral issues, especially more so in youth. Can look like yelling or screaming, physical aggression and self-injurious type behaviors. All of those can be present. So as I said earlier, 15 to 20% of the general population, and generally speaking, the comorbidity with other psychiatric conditions is the rule rather than the exception. So if you have an individual or if you have a person who has another psychiatric condition, such as depression being very common, we want to always be looking for the anxiety, because it's very common that those two go hand in hand. It used to be that we thought that folks with intellectual or developmental disabilities could not have neurotic type psychiatric conditions like anxiety or depression. And this goes way back to Freudian thinking, when you had the id and the ego and the superego. And your id is wanting all these drives, so you want to eat, you know, and fun, have fun. And then you have your super ego saying, no, 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 don't overeat, you'll gain weight. And you have your ego, your sense of self in the middle, trying to balance those two things. And in early psychology and early psychiatry, so we would think that the psychologists felt, well, there wasn't enough ego in folks with intellectual disabilities, so they can't develop a neurosis. And so that's where we saw this kind of split in the treatment of intellectual disabilities from mental health. And that split even exists to this day, although we now know that actually those numbers are even higher rates in folks with intellectual disabilities, have anxiety and other mental health conditions. But we still have these archaic systems, and that's why we have, you know, training centers apart from state hospitals. That's why we had, you know, our Department of Behavioral Health independent from intellectual disabilities. They come in sections, and pretty much across the country. That's the history of how those things develop. Just a fun little historical fact. But as I said, we know now that, you know, you're actually, if you have an intellectual or developmental disability, you're more likely to have a mental health condition than the general population. Not staggeringly more likely, but somewhat more likely. And we see this especially in in high functioning autism with anxiety disorders. And I'm going to talk a little bit later about kind of why that is and what we see in that pattern. Two take home tidbits to understand about anxiety. So when you're trying to support a person with anxiety disorders, okay, two tidbits about that. One is it tends to be lifelong, and two, it tends to be genetic. And why are those two tidbits important? Well, it tends to be lifelong, and that's very important to know, because when you're working with somebody with anxiety, that they don't necessarily know what it feels like to not have the anxiety. Okay, so for them, anxiety is normal. Even though they know it doesn't feel good, and they can tell you, I don't like how it feels, and I'm not sleeping well, and they know they have anxiety. Cognitively, they understand it, but they don't know what it's like to not have anxiety. All right, and unless it gets treated, or sometimes, as we see in our, you know, general in the world around us, sometimes people self-medicate. They use alcohol or things like that, and they notice, oh, I get a temporary fix, if you will, of you know, reduction of my anxiety. But it's important to know that. And we all know these people growing up, right? They were the folks in school who were, hey, what'd you get on the test? Oh my God, I failed the test. I got to, and they would study really hard, and they stay up all night studying for the exam. And they vomit 3 times and drink a pot of coffee. And if they were smart, they got in, you know, they did well on their exam, but that reinforced it. So the next time they had an exam, they did the exact same things. And they would often, you know, drive themselves a little bit, you know, hyper and a little crazy there, and drive everybody else a little bit crazy. We know that that's kind of a generalized anxiety picture, but they don't know what it's like to just turn it off. The second point is, again, that it tends to run in families. So we tend to see a high genetic concordance with that. And that's also important to know in supporting systems. And again, I'm sure for all of you, especially in the school systems, where you have maybe worked with a child who has an anxiety disorder, and they're really just hyper and worrying about everything. And then you meet the parents in a conference, and you go, oh yeah, I see where that came from. That's what that is. The other thing, though, that I like to look at and in consideration of that is when we talk about things as conditions or disorders or illnesses, remember that anxiety often is a double-edged sword. And I will pause it. And so when I'm talking with families or systems or patients, I will often talk with them and say, well, you know, everyone has a different type. Everyone has a different personality type. You look at maybe actors, you look at Woody Allen, that kind of highly neurotic, oh my God, everything's bad. Or you look at Jack Nicholson, and everything's really cool and chill and laid back. And you say, okay, well, those are personality types. One's a little more anxious, one's less anxious. But in the general population, we see that. And when we have somebody, we say, well, they have anxiety. It's a double-edged sword. There's strengths that come with anxiety. People that have anxiety check up on things. if I had to get the wedding cake delivered to a wedding, am I going to ask the really chill slacker guy who was great and fun at the bachelor party, or am I going to ask the anxious, neurotic, bridesmaid who plans everything in a planner and highlights, on a timeline? Who am I asking to bring the wedding cake? There's a no-brainer there, right? So remembering when we're talking with folks and we're supporting individuals that it's important to just keep that strengths-based approach in mind. So those are kind of some take-home tidbits, and really, if you don't get anything else out from this talk, but those kind of tidbits, you're hopefully giving some food for thought in how you're working with folks. It wouldn't be a psychiatrist talking if there wasn't a picture of the brain. We're required by law to have brain pictures on our presentations, but this is kind of how anxiety works. You have something that's called your automatic or autonomic nervous system. This is where your heart rate, your blood pressure increases, your eyes dilate, you get ready for something, the old fight or flight reaction. The amygdala is the area of the brain that where that comes from, and in getting ready in that. And what happens as anxiety is it just gets overaction. And when that happens, it also has downward effects on hormones, so adrenaline, cortisol, insulin increases, right? So your body's getting ready to say, okay, we got to burn energy, so send out the insulin. Thyroid is metabolizing proteins and things like that, helping your body's metabolism kick up. And so that's what we see as this overreaction. And of course, this part of your brain is your cortex, and this is the front of the brain here, and this is the back of the brain here. And so your environment, you get your intake, your sensory intake. What happens in anxiety disorders is this area is overreacting. So talking very briefly about the different types of anxiety disorders. I'm going to go over these pretty quickly, but hopefully maybe give you just kind of an example of each one. So, but I want you to get the flavor, because when you have anxiety, all anxiety is not equal. All anxiety is not just worry. When you have anxiety and you're trying to identify how we're going to help this person, you got to get kind of the flavor of anxiety. And that can help you in figuring out how to support them. So in certain situations, you may want to extra engage. In certain situations, you may want to back off. And so which situation do we wish to do that? There's some tools that you can use, like teaching deep breathing or yoga or meditation, that are very helpful kind of across all of the anxiety disorders. And certainly those are resources that I would say encourage. While I'm thinking about it, because I'll probably forget later, if you're teaching tools like meditation, yoga, deep breathing techniques, it's important to practice them. And it's important to practice them not when the anxiety is bad. So if I'm teaching somebody deep breathing, I'm doing it calmly in my office, and I'm having them do it 3 or 4 or 5 times a day, where it's an in through the nose, out through the mouth pattern. It's usually 4 or 5 seconds in, 5 or 6 seconds out, a little longer. So, and it's sitting and breathing through your belly. I can see my belly here. So it's a breathe through your belly. And then, and you do that just 5 or 6 times, right? But it's important to practice it, because if you only bring that tool out when you're anxious, it's going to be right. That's not gonna help. So when we're using tools out of our toolbox, like meditation, yoga, deep breathing techniques, imagery techniques, important that those are being practiced during calmer periods. Now, some people seem to be anxious 24/7, but it peaks and flows across that. And you want to have ideally a quiet environment in which to do that. So that's just while I'm thinking about that, when you're using those tools, make sure you're practicing them. Make sure you're practicing them, not just during anxious times. So you don't say, okay, next time you feel like you're having a panic attack, practice your deep breathing. No, practice your deep breathing 4 or 5 times a day, 30 seconds tops. Oh, also on deep breathing, little shortcut. And this data just came out. And I'm going to make all of you do something here in just a minute, involuntarily, or at least 50% of you do this involuntarily. But I want you to try it here. And it's going to be a double sharp breath inward through the nose like this. Okay. And what that often does is it quickly kind of gets a person stopped and brings that anxiety on. You can do it once or twice, but it'll often probably, and I guess 40 to 50% of you also yawned when we did that. If not, you will shortly. So that's a little magic trick courtesy of the psychiatrist. So let's jump into the different types here. So generalized anxiety disorder, this is just your general worriers, day in and day out. It's the one we talked about earlier. It's the person who's like, everything is just this, highly constant state of worry, fear, dread. Everything's going to be, difficult or bad or hard or go wrong, and it's often very out of proportion, unrealistic. And so a lot of what we call catastrophizing, and it may be about several things in particular. It's usually about lots of things. It's not, I'm only worried about my health. It's, money and family and school and, work and friends. And it's kind of generalized all over the place. And it's not with generally usually discrete panic attacks, and not a specific phobia that happens. And again, all of these really need to have occurred for a period of 6 months that we see before we officially label them. It doesn't mean that we don't, if we start seeing, especially with kids, you start seeing these things, you want to address those early. So if you're seeing these patterns in family members or kids, you want to, address that early. You don't want to go, okay, we'll wait 6 months and really make sure they have it. The 6-month thing is for the therapists and the docs to make sure that they've got that documented before they reach into their bag of medications and things like that. But therapy and things like that can be very helpful, and even medications early on. So again, same kind of general symptoms that we see here. This one in your school systems, constantly needing to go to the bathroom, difficulty with falling or staying asleep, trembling and being easily startled. In our folks with IDD, communication may be a challenge on there. So it's important to really look at how a person is presenting. And again, things like, are we seeing frequent incontinence or needing to go to the bathroom? Is there difficulty with sleeping? Do we seem to see that the face changes? So we know kind of what worry and fear looks like, but are we seeing tightness, around the neck and things like that? So we may not be able to ask, are you catastrophizing about things? But we can see that they get tight. Okay, so that's important in our folks with IDD. They may not be able to communicate as well to us, or they communicate it at an angle. Perhaps in a third person way, or they focus on other areas such as the physical symptoms of it. So not unusual in IDD that what you will hear in generalized anxiety disorder is my stomach hurts. Okay, that and we're sending people to GI doctors and things like that. And sometimes it can be an anxiety disorder there. So panic attacks are very acute, extreme anxiety attacks. So it's a sense of I am losing control. I'm going to pass out. I'm going to die. I'm going to be stuck here. Nobody's going to be able to help me. I'm having a heart attack, and it's an extremely intense. It can usually come randomly. It can be triggered by things. But it often occurs just randomly. A person may be just in the middle of having a pretty decent day and a panic attack happens, or it wakes them up in the middle of the night with a panic attack. So, seeing some of these types of symptoms, but tends to peak in 10 minutes. So the person was feeling like they're dying, but they're not going to die. And any ER physician will tell you, man, they've seen tons and tons of panic attacks, people coming in thinking they're going to have a heart attack. And they work them up and make sure they're not having a heart attack, but then they go, it sounds like you had a panic attack. In our folks that we work with, that panic attack, again, if a person's not able to communicate well, it may lead into more of a behavioral, extreme pacing, Again, the face is going to look like a panic is present, and maybe yelling or screaming. But again, like I said, how do we differ this from the person who perhaps has behavioral difficulties when they don't get the cookie that they wanted? Well, there's not usually an environmental trigger here. It comes kind of out of the blue. And so when we're starting to see these kind of things, do see, okay, is there a panic attack going on here? Specific phobias, we know about these. These are unreasonable fears cued by a specific object or a situation. So if you were afraid of spiders and a spider crawls up your arm, you're going to have some panic type like symptoms. That's a specific phobia. You may not go into basements or closets because you have this fear of spiders. Or maybe it's extreme and you don't go out into the woods or the fields because you have a fear of spiders. So there's avoidance with that. And most all of us have some degree of phobia. All right, that's, so some people who don't like spiders at all will say, well, that seems to be a logical thing because spiders can bite you and we don't want to be bitten by spiders. So I avoid generally not putting my hand in a spider web for fun. That doesn't sound like a good time to be. And my apologies in advance for any of you out there in the audience that have arachnophobia, that I've mentioned the word spider 11 times already. So my apologies on that. But many of us have basic kind of phobias. The difference is that it interferes with functioning. Okay, so if I have a fear of great white sharks and I don't go swimming in the Pacific Ocean, that's not really interfering with my functioning. Unless my job required me to swim in the Pacific Ocean, then it might. But if I have a fear of sharks and I don't go into the local swimming pool because of that, that would be a real, truly what I would say a specific phobia that interferes with my functioning. And it's not OCD or PTSD, et cetera, et cetera. Same thing here. Unlike though in panic attacks, we will see that there is a trigger usually. It may not be direct, that it was the fear of the spider that, that I saw the spider and it caused these crying, yelling, pulse rates, tension, screaming, pacing. It may be that I'm doing an avoidant behavior because I'm afraid there's a spider in that place. And sometimes these can be really tricky to figure out, especially if we have folks who are nonverbal and not able to sign well or communicate well. So folks with communication deficits, these are sometimes tricky and can linger, unfortunately, for years before somebody goes, wait a minute, I remember the last time we went to X, Y, or Z place and they had the same exact problem. Okay, what's at X, Y, or Z place? Oh, well, there's snakes at the exhibit there that we went to at the zoo, and the snakes were in the big reptile pavilion, and that's when they absolutely had a problem. And then they put two and two together and go, oh, this person's afraid of snakes. In our childhood and working with kids, and we wanted to, and since we have a lot of our folks here working with youth, it's worth noting about separation anxiety disorders. So we'll spend a minute or two on this. So this is kind of, again, inappropriate and excessive fear with separation from attachment figures. And what are attachment figures in our world? Well, they could be, family members, they could be teachers, they can be, if a person lives, say, in a congregate group home setting, it could be favorite staff. And pretty much anybody that would be that they see as an attachment figure. This can occur and have this fear of separation. And there's usually some excessive worries that, when I'm away from, and I'm just gonna use mom and dad as the generic term, but when I'm away from mom and dad, there's worry that something's going to happen to them. They're going to get sick, they're going to be in a car accident. And there's fear about, even as I say, okay, well, we're going to go to school now, and there's an absolute aspect of separation that happens, of anxiety that happens with the anticipation of, oh, I got to go to school, it means I have to leave mom and dad. and something bad's going to happen. So now my anxiety is increasing. Generally speaking, folks like this don't want to be left alone. They don't want to do sleepovers with their friends. They may have nightmares with that theme of separation. Okay. And often, again, what we see in anxiety disorders, physical complaints. Generally speaking, this tends to be a condition that's mostly in childhood, and generally speaking, most children to a certain extent grow out of it over time. But what we see in IDD is that not unusually adults with ID can have this kind of separation anxiety. And so when we are working with our folks and we see maybe things that look like separation anxiety, don't assume that because they are 30 or 25 or 40 or whatever, that they don't have the potential for separation anxiety disorder. Especially if their, individual cognitive, emotional and social development is more at a childhood type level. I could spend an hour talking to you about do not treat adult IDD folks like they are children. So hear me clearly on that, and I won't spend an hour talking about that. But it is worth noting that we do occasionally see separation anxiety disorder in adult age folks. You can even see it in non-IDD folks, but it usually tends to be more of a development of a dependent personality, where the person is kind of just always needing to be with people, and they're very dependent on other people. And that's often where separation anxiety goes to in adults. They don't have the extreme anxieties about being alone, but they work around creating this kind of dependent mindset. And that's kind of one of the risk factors when we look at something like dependent personality disorder. Totally different discussion for perhaps another time. So the developmental effects that we see that can alter those clinical features, similar to those that were described for children without ID. So that we may see that are kind of quote unquote normal depending on age. So again, at the beginning of the talk, we talked about, okay, well, how do we distinguish what's normal anxiety versus what is an anxiety disorder? And so it's important to note that when we are making these assessments, that just because we see something that looks like an anxiety, if it doesn't follow a specific pattern, so a 2-year-old throwing a temper tantrum isn't having an anxiety disorder, or a 2-year-old freezing up or crying, or a 4-year-old having nightmares, or a 3-year-old being clingy. These things aren't necessarily always going to be, oh, there's an anxiety disorder. So you want to look at those patterns and also identify developmentally where those things are, and do they progress out of those things as they developmentally move on. What are some of the other factors that we see about folks with IDD overall in anxiety disorders? Usually the anxiety is more intense in folks with intellectual and developmental disabilities. They also tend to have fears that are similar to, again, the mental aged match controls. So, fear of the dark that reaches a point of causing an extreme level of impairment. We're going to see that often in, kids between the ages of 2 and 5. Okay, we will see that also commonly in individuals with intellectual disabilities who have quote unquote mental age match controls. And again, my caveat, do not treat adults like they are children, but it is worth noting that you may see a similar developmental pattern there. And with that similar developmental pattern, that similar risk factor for that anxiety to become a disorder. Fears reported by young children stated by an adult might appear to be bizarre. So a 5-year-old telling us that they think that there's the boogeyman in the closet and in the shadows is probably not going to lead to a lot of angst by the parents. But a 25-year-old saying it, they might say, okay, these seem to be psychotic or bizarre. Very important that we identify if there's anxiety in there, because we don't want to treat those things as being quote unquote psychotic and using correct medications or treatments in that situation. So being aware of where a person is kind of developmentally and not making an assumption that that something is either psychotic or, in the second stage, primitive. So that, again, like I talked about, some of those primitive fears with that kind of developmental age matched control. It's important that we don't overreact to those and say, oh my gosh, this is psychosis. It very well could be anxiety. And of the two, anxiety is much easier to treat than actual psychosis. Just some other general factors, again, to be keeping in mind for you guys. Informants, and so people who are observing the individual that's having anxiety often underestimate the impact of stress. So if you remember back to the brain, I talked about it affects the hormones, the cortisol, the thyroid, it affects your development of your heart and things like that. The impact of stress on people with ID, we tend to underestimate the impact. We can say, oh well, that's just behavior, and they just need to get over it. Unfortunately, that's a common pattern. And so we see that a lot of folks with IDD have untreated anxiety. Another thing to remember in the considerations is that we tend to often see regression in response to stress. So a person who maybe doesn't have the cognitive toolbox to dealing with the stress of life is more likely to deteriorate or regress and end up spending more time in that anxious state. So that lower threshold is there. So because of that limited cognitive reserve that's there. And again, when a person fully goes into a regressed state like that, it can often look quite bizarre or psychotic. Another interesting phenomenon is when we have periods of acute or heightened anxiety, sometimes we get this kind of baseline exaggeration. And that's where the person, is kind of in the always anxious state. And we just kind of go, okay, well, that's kind of their baseline of exaggeration is catastrophizing. And that's an interesting phenomenon we see ID and non-ED, but more likely in IDD folks. And as I mentioned before, we often miss it because we may see it as a challenging behavior. That we miss it in two areas. One, we label it as something more severe like psychosis, or we label it as something less severe as, oh, well, that's just that person's behavior. And so it's very important that when we see something that seems to be causing disruption to this person's life, that we have that addressed. All right, and I mentioned before about the comorbidities, depression, dysthymia, bipolar disorder. OCD I mentioned. Now OCD is now, even though we used to consider it an anxiety disorder, it's actually its own spectrum, but it has an anxiety component where you'll see obsessions and compulsions. So when we, and I'm going to talk about that in a minute when I get to autism, because we're going to talk about autism versus OCD. So what are you guys looking to do? What are the things that y'all are looking at? Somebody that's pacing and fidgety, and what could these things be? And I have this little slide here, but yeah, it could be anxiety, but it could also be a side effect from medication called akathisia. Or it could be the person's uncomfortable and has constipation. So what's the point of that? Well, one of the things I teach is biopsychosocial thinking. And so make sure that when we are identifying somebody that's looking like they're having anxiety symptom, pacing, fidgety, tense, maybe headaches, maybe stomach ache, that we're making sure that we're getting that person checked out medically. We're getting that person checked out psychosocially, what's going on in their environment. And we're then addressing and identifying what could be those sources of that. Now, as I mentioned before, the effects on the brain, neural circuitry, and chronic stress actually changes the physical structure and function in the brain. So let's talk for a second about some of the genetic disorders that you can see out there that are not unusual. So there's a couple out there. Williams syndrome, very commonly. We commonly see that with a high degree of fear and anxiety and irritability. There's a number of genetic disorders out there, so I'm not going to go over all of them. But if you look at some of the facial type features there, and the Fragile X syndrome, and I always remember just Michael Phelps kind of has a similar facial presentation there. Not known that he has Williams syndrome, so that be very clearly. Fragile X, also very high rates and high comorbidity with autism spectrum disorder. We're going to talk for just a few minutes about autism spectrum disorder, and what I would like you guys to have as a take-home message is that one of the challenges we see in autism and anxiety is understanding. All right, sorry about that. Is understanding that when you have an anxiety disorder, when you have autism spectrum disorder, as you develop from childhood on, your peer group socially has a higher slope on the curve. So we see that social interaction gets harder. So a 2-year-old with, especially with higher functioning autism, they may be able to kind of do okay socially with their peer group. But as those children get older and as they age, that gap becomes wider and wider. And so it becomes more challenging for a person with autism spectrum disorder as they get older to engage with the world around them socially. And that is something that I call the social gap. And that social gap often leads to anxiety. And often in a person with autism spectrum disorder, it leads to that person turning more inward rather than outward to address that social gap anxiety. And that's a very, very important construct and not one you will hear taught very much. And especially in psychiatric circles. And when I teach this to other psychiatrists, you can see the light bulbs go off in their head. Because if we look at medications that are FDA approved for autism spectrum disorder, we only have 2. And those are Risperdal and Abilify. Both of those medications that are approved for irritability secondary to autism spectrum disorder. And that's a very, very poorly formed diagnosis. In fact, it's not a diagnosis at all. There's no such condition called irritability secondary to autism. And so we end up with these tranquilizing type medications, not to bash them. We use them, they are good medications, but they aren't really anti-anxiety treatments. And one of the unfortunate things that I think we see is an overusage in the IDD world, and especially in the ASD world, of these types of medications in treatment where anxiety is probably the primary symptom. And so as advocates out there, be aware that asking professionals to look at this through the lens of anxiety rather than through the lens of irritability can make a huge difference in the treatment plan. So looking at working with therapists to identify what are the anxiety sources and looking to the prescribers to say, can we look at this from treating it from an anxiety point of view? instead of from a tranquilizing psychotic point of view. And that can really make a huge difference in that. Now, that being said, there are aspects to, anxiety when driven to an extreme degree. When a person who has IDD and doesn't have good coping skills, or may have cycling patterns of mood instability, that low doses of those types of medications as adjuvant treatments, that is additionally to maybe some baseline treatments in low dosages, can be very helpful and very useful. But that's just an important take home, is think about that social gap, anxiety that comes from that social gap, and then that externalized dysregulation that occurs from that. Add to that, the challenges with executive functioning, the sense of inflexibility, difficulties with coping with change, and the sensory sensitivities that are there. And you can understand where autism spectrum has so many layers of potential anxiety promoting areas, that it can be very, very challenging. But the one important message in working in that situation is, when we see anxiety, be contemplating first, working with identifying where the flavor is first. So anxiety and IDD, identify what the flavor is. All right. Start getting some tools in the toolbox, deep breathing, meditation, whatever those tools are, work with a therapist on those types of things. Okay, identify what those potential and biopsychosocial triggers are that may increase the anxiety, and work on avoiding those, whether that's sensory issues, whether that's person has irritable bowel syndrome and gets constipation easily, doesn't have a bed that works well for them, they need a new bed to help them sleep better, whatever those things are that may be contributing to that. All right. And then working with other healthcare professionals to say, okay, let's identify this through the lens of anxiety, and make sure that we're treating that. Again, it's the most common thing that's out there. And then, of course, watching out for other things like depression or bipolar disorder. But those are fairly discrete symptoms. The other thing about autism spectrum disorder is really the overlap with obsessive compulsive disorder. I'm not going to take a lot of time to go into that, because I want to get to these next just couple of slides before we open it for questions. But obsessive compulsive disorder versus autism spectrum, is important to denote that in obsessive compulsive disorder, the person who has obsessive thoughts, like I'm thinking about germs, everything has germs on it, right? And compulsive behaviors, I have to wash each finger 7 times. Okay, that would be in a compulsive behavior. And if I miss one, I have to go back to the beginning. We call that undoing. I have to go back and do something different, or maybe I have to go like this and then go like that, or whatever it is, clap my hand twice and then do it. The person that has OCD has an awareness, generally, as best as we can tell, that this is uncomfortable to them. Okay, whereas the obsessiveness that we often see with routine and structure in autism spectrum disorder actually is a mechanism often of release. So the person who has autism spectrum disorder but does compulsive things, maybe they line up things a certain way or like things just so, they or obsess over specific patterns. They may be really into trains or into sharks or whatever. They are not uncomfortable with that. In fact, that makes them feel more comfortable. Now, you pull those things away, they get uncomfortable. All right, but that's the difference between OCD and what we see in the OCD-like symptoms, the obsessions and compulsions we see in autism spectrum disorder. I always like to make sure that we're clear on that, because we see that, and I can't tell you how many times I've had somebody with autism spectrum disorder come to me with a diagnosis of OCD, and they didn't have OCD. And so treating it as OCD is not the right route. So what are some of the things you can do? Some global strategies: reassurance versus prompts. Okay, we language. Let's us do this. We're okay. Not I need you to calm down and do this. All right. Recognizing that moodiness, aggressiveness, self-interest type behaviors can be related to sensory issues. It could be related to the anxiety issues.
whatever support you're doing, you want to address the source of the anxiety. All right, very important to remember that. Supports must address the source of the anxiety. Keep the sensory environment calm, right? Avoid noises, crowded places. Anything that tends to make us anxious is going to make an anxious person more anxious. So just remembering that. So helping folks with transitions, things like social stories can be very useful. This is across ASD, Fragile X, IDD, the whole 9 yards. And I cannot emphasize strongly enough the sensory challenges, right? If you guys, hopefully you all up there have good access to OT sensory evaluations. And if you don't, figure out how to get them. We have Cornerstone Therapy down here with Wendy Atkinson. We have Making Strides down here in the Richmond area. Both are 2 excellent areas that have OT sensory. When I first started in this business, I was sadly going, okay, well, that looks like it needs medication. And then, figured out, oh my gosh, no, they need headphones and swings and not medications. Patterned routines are helpful. We do know that breaking a routine tends to increase anxiety, but the routine itself can be helpful. Using visual aids, so your PEC schedules, your calendars, your first then cards can be very helpful. So why is that helpful? Well, again, what I said, generalized anxiety, it's always worrying about the future. Well, if I know this is first and then we're doing this, okay, first, then this, that's very helpful in reducing the then anxiety. Okay, and you can break it down into as many little pieces as you need to. And again, using social stories or role playing around that. Same thing with timers, countdowns and things like that can be very, very useful. Hopefully that was a lot of information, but hopefully that kind of gave you a flavor. But the reminder is, observe, mark down what you're identifying as possibly anxiety, find the flavor of it, get some tools. We just talked about a few tools there. And then get some, professional assistance with that. And remember to practice when you get the tools in hand. There are some things that we mentioned that can be one size fits all. But once you're working with a therapist, on these types of things, and I generally say you start with a therapist. You start in the therapy space, and then you work with them. If you need to, go to a prescriber and say, okay, but remember to advocate, to say, look through this through the lens of anxiety. Advocate for that. Do not assume that the person with the prescription pad is looking through the lens of anxiety. We miss that often.